Good evening, all. Welcome for 58th episode of Dr. K.K. Agarwal Med Talks. Today we have to discuss on role of probiotics in the management of dyspepsia. I am Dr. Santosh from the medical advisor from team. Welcome Dr. Prerana Goyal, senior medical consultant and deputy medical superintendent, RG Stone and Super Speciality Hospital, Ludhiana, vice president of Wincars. Welcome.
Thank you so much. Very good evening to everyone. Thank you, Dr. Santosh, and thank you to the Med Talks by Dr. Kiki for giving me this opportunity to talk about a very interesting topic. And I think it's an upcoming topic that is the role of probiotics in the functional dyspepsia or in the dyspepsia in general.
Yes, ma'am. Ma'am, what is the what we want to understand? What is the prevalence of dyspepsia? Because in many places it will vary depending on the condition and the patient. So, what is the prevalence in your practice?
Sorry, once more. I think
Yes.
you are not audible to me.
Okay. I will. What is the prevalence of dyspepsia in your clinical practice? Okay, yeah, there is some technical issue from Dr. Prayer Goel. He will join in 5 minutes. Sorry for inconvenience because of the technical reason.
Sir, you can start your presentation till now.
Yeah. Uh, yeah, apologies for the technical glitch. Dr. Prerna Goel will join you soon. Before that, I thought I will share the presentation. Okay, I think it will take some time for processing of this presentation. So today's topic is, we know that role of antibiotic in the management of dyspepsia. As you're aware that it is a heterogeneous diseases. There is various groups of symptoms which is patient complain mainly from the upper abdomen. Sometimes the patient complaint of epigastric pain or sometimes burning. He will come to you with a after the having a lunch, dinner or something. He will come say that's a fullness. He will come with you with saying that there is a epigastric pain or burning sensation. After having a lunch or dinner, he may have a post fullness in the stomach. Then satisfaction, early satisfaction. They that before starting they see or he may say that okay enough for me today. So they, and but along with that have there is an absence of any structural or any lab investigation, including the upper GI scopy. So there is a two types. We will say organic and functional dyspepsia. We will definitely come to know what is the functional and dyspepsia. This is the range which usually say 20 to 40%, but it is very high because no patient comes to you with only the dyspepsia as a complaint. So definitely it is very high, but 20 to 40% is actually less with the, you know that with the our diet, especially for Indian diet, it is a very rare prevalence here mentioned is completely low compared to this. But if you have the patient have a disorder, not that normal dyspepsia, maybe because of some pathological reason, only the 3 to 5% of the patient come to the primary care visit in this. Among the patient which is for the dyspepsia complaint, 70% comes with a negative endoscopy studies, and that is why we consider as a functional dyspepsia. There are many risk factors for the dyspepsias like female sex, age, increasing age, H. pylori infection, which is most common in Indian area, socioeconomic status, executives, uh, high end jobs, smoking, alcohol, along with that NSAIDs usage continuously. This is the very small amount or risk factor, but there is a very big list of the risk factor which we will encounter in day-to-day practice. Coming to this, what is the organic and functional dyspepsia? Organic, which I told that is actually it is from this secondary cause. Maybe the peptic ulcer. That's why patient will come across with the dyspepsia. Gastroesophageal reflux diseases, cancer of gastric and esophageal, pancreatic or biliary disorder, intolerance to the certain amount of foods and drugs, other infectious or systemic diseases. Majority of the patient have the complaint of GRD, that is the reflux disorders, because of this condition. Functional dyspepsia, that may be a pathophysiological and the pathogenesis factors. Pathophysiological causes like there is a delay in gastric emptying because some other region or because of the age related factor also. Impaired gastric accommodation to the meal, and that may leads to indigestion, which sometimes patient will complain to it. Some patient are very hypersensitive to the gastric distension. Altered duodenal sensitivity to the lipid and the acid. That's why there is a reflux from the duodenum to the stomach. Altered, that's why leads to altered jejunal motility and gastric electrical rhythm. Any changes in the rhythm from stomach to duodenum, jejunum, it will leads to functional dyspepsia. Unsuppressed postprandial phasic contractility in the proximal stomach, that's and autonomic nervous system or central nervous system dysregulation. Usually in the stress, strain or something like in the most full condition, the patient may complain on the functional. Along with that, there's a pathogenic factor like genetic. More some patient or some people are more prone for any food, acid or any spicy food compared to others. H. pylori infection, which we discussed, it is most common is inflammation and the psychosocial factors. These are the broad of this role of probiotic in the. What are the symptoms? The symptoms are vary depending on the condition. Yes, Dr. Prerna, you're able to.
Yeah,
Yes, ma'am. Yeah. We will go. We already started with prevalence and this thing. I will. I think stop presenting and discussing. Yes.
okay.
Ma'am,
Yeah.
we are discussing about the prevalence of dyspepsia. We thought that 20 to 40% is the what is that academic or the journal. So what is your like in how many percentage of patient you see this kind of dyspepsia prevalence?
Okay. See, the prevalence, the community prevalence of dyspepsia is in the range of around about 20 to 40%. The data varies as per the geographical location. If we compare east from the west, if we talk about the Indian population, in Indian population there are various studies which quote a prevalence of in the range of like 7 to 40%, with an average prevalence of around about 30%, and around about 10 to 40% primary care visits are because of this dyspepsia only. Like in Chandigarh, there was one study which showed the prevalence of around about 7%, and in one study it was around about like 40%. So overall prevalence in Indian subcontinent is around about 30%. The prevalence actually varies from geographical location depending upon the criteria which are used to define dyspepsia. The Depending upon the interpretation of the dyspeptic symptoms, and so there are so many other factors which can actually affect to define what is the actual true prevalence in a particular community.
Yes, yeah. There is because already there is a lot of questions are coming up in the comments. So one of the questions they say that there is a definition of dyspepsia. It is a heterogeneous group of syndrome. So
Yeah.
can we able to tell like what kind of syndromes we have to look into in the patient?
Yeah. See, dyspepsia word actually is a Greek language word which literally means that is indigestion or bad digestion. So once a person complains that he is suffering from dyspepsia, which he means to say that he is having some indigestion, that actually opens a Pandora box for the clinicians, because there are so many symptoms or presentations, maybe in the form of heartburns, belching, bloating sensation, early satiety, loss of appetite, abdominal pain, abdominal discomfort. But being a clinician, we have to define whether patient is having truly dyspepsia or not, and if dyspepsia is there, what kind of dyspepsia is there. For this, we have a very objective criteria which has been given by Rome 4, and it was given in 2016. They have beautifully simplified the definition of dyspepsia. According to Rome 4 criteria, dyspepsia is defined as either episodic, recurrent, or persistent symptomatology that is thought to be originating from gastroduodenal region. So the symptoms which are originating from the stomach and the duodenal part, they are classified into dyspepsia, and plus which is affecting the routine activities of a person also. So this is an important criteria which has been formulated by Rome 4 criteria. And if we talk about further subcategories of dyspepsia, dyspepsia can be uninvestigated dyspepsia till no further investigations has been defined, and we can have investigated dyspepsia where we have some kind of investigations. And many of the times we have some secondary causes of dyspepsia like peptic ulcer disease, gastroesophageal reflux disease, some kind of gastric or esophageal malignancy, and some kind of infections and some kind of the medications which can affect cause dyspepsia, that are called as the secondary causes of the dyspepsia. And if we have no secondary cause, which is obvious after a routine clinical evaluation, we call it as a functional dyspepsia. So, functional dyspepsia in general is a part of the four categories. If we define the functional functional gastroduodenal disorders, there are four categories, which is nausea and vomiting syndrome. The one is belching syndrome, rumination syndrome, and functional dyspepsia is the fourth category. So functional dyspepsia is defined when the person is having dyspeptic features, but on a routine clinical evaluation, we can't find out any primary cause. That then we call it as a functional dyspepsia.
Yes, it is nicely summarized. So, we are discussing about risk factors. There is a we discussed female sex, age, H.
Yeah.
pylori. Then any other risk factor which you encountered in your practice?
Okay. See, dyspepsia, obviously, females increasing age. The one more important thing is the socioeconomic status. In East, what has been seen that it is more common in the persons having a higher socioeconomic status, whereas in the Western data shows that it is more common in the persons having a lower socioeconomic status. Apart from this, education level, low education level is also associated with this more of dyspeptic symptoms, and the food habits including the smoking, caffeine intake of the citrus fruits, high fat foods. So all of these are associated with dyspepsia, but definitely correlation of caffeine and alcohol has not been there with regard to the dyspepsia, but yes, smoking itself leads to. And other important risk factor is the H. pylori infection. The areas where we have higher H. pylori incidence, this is also one of the contributing factors for the dyspepsia.
Yes. Yes. You told about low socioeconomic. How high socioeconomic population comes to dyspepsia? It may be the same stress factor or any other factors for them.
Yeah, high socioeconomic status, just like we see in the west, in the east, sorry. It's basically more of psychosocial factors because dyspepsia is, as we all know, that it is a altered brain gut interaction. So stress in any form, maybe in the anxiety, depression, or some kind of peer competition. And the other thing is the changing in the lifestyle. The higher socioeconomic, they have different kind of lifestyle, like they are more into the highly processed foods, and the type of the dietary pattern is quite different. So in that ways, and also the alcohol consumption, smoking consumption, that is more in the higher socioeconomic classes. So that could be a contributing factor for the dyspeptic symptoms.
Yes. You already discussed about postprandial and epigastric pain related dyspepsia. So, any differences or they sometimes overlap each other?
Yeah, dyspepsia, functional dyspepsia is basically divided into three categories. One is the postprandial distress syndrome, which is there in approximately 38% of the cases of all functional dyspepsia. The second one is the epigastric pain syndrome, which is present in approximately 25 to 27%. And the third important category is the overlapping, where we have overlapping features of both post distress and one is the epigastric pain syndrome. There is definite criteria which has been given by Rule 4 when to label it as a postprandial distress syndrome. That is when the person have food and they have onset of dyspeptic symptoms, and the duration they have mentioned it should be more than 3 days per week for at least the last 3 months, and the symptom onset should be there at least 6 months before the onset of diagnosis. The same way epigastric pain syndrome is when the person is having either epigastric pain or burning or discomfort which is severe enough to affect his his or her routine activities, and should be present at least more than 1 day per week for the last 3 months, with symptom onset at least 6 months before the diagnosis. And but 35% cases can have overlapping of both postprandial and epigastric pain syndrome. So from the clinical history, we can have a rough idea whether this is which kind of subcategory of functional dyspepsia the person is suffering from.
Yes, that is a very nice summarization of clinical evaluation. Any other diagnostic evaluation which you usually prefer to do for this patient?
Okay. Once a person comes with dyspepsia and you're sure that the person is having dyspeptic symptoms, then various other factors that have to be considered how to approach this patient. One is the history, and one is the physical examination. The other important things are, we can see for the H. pylori, because if there is high incidence, high prevalence of H. pylori in a country, in a sub geographical location, then person can be sent for the H. pylori testing and biopsy. The other important thing is the severity of the symptoms and the presence of the alarm features. Suppose a person having dyspepsia along with presence of alarm features, which we say the person is having either significant weight loss, that is more than 5% of the baseline weight loss, or the person is having some kind of overt GI bleeding, person is having iron deficiency anemia, or if the person is at high risk of some malignancy. Suppose in China and Japan, the inhabitants, they are more risk of gastric carcinoma, and if there is any family history of some kind of gastric malignancy or esophageal malignancy, then these all are the alarm features. So once a person comes with dyspepsia, we have to consider all these factors, and accordingly we can proceed for the diagnostics. If the person is having alarm feature, age group is more than 50. In India, we take it as the 50, but otherwise, according to American Gastroenterology Association, it is more than 60. They say that the person should be sent for the esophagogastroduodenoscopy, that is the routine endoscopy, just to rule out any secondary cause for the dyspepsia. If there is no alarm feature of the person is less than 50 years of the age, then we can think of H. pylori testing, and accordingly, if the test result is positive, then treatment for the H. pylori, and the treatment is negative, then we can think of empirical starting with the PPI therapies. But if person is not responding to some kind of the therapies you are giving, then very rarely test which can be considered is the celiac disease, because wheat allergy is quite common in India, so that can be considered. The other is the testing for the gastric emptying, which is not easily available, like scintigraphy testing, which can be done. And apart from this, we should review the drug history of the person and the dietary history of the person. So the main diagnostic test includes esophagogastroduodenoscopy, but in what kind of the setups and what kind of population we should go for, that depends. And the other one is the H. pylori. These are the two basic tests which should be done.
Yes. You told that in from H. pylori or any other symptomatic, you start with a PPI. But there is a lot of doctors are asking there is a adjuvant therapy like a herbal therapy, something like FD guard. They are saying that then ginger and water or HDW5. It is a herbal
Yeah.
medicine. What is your intake on this?
Yeah, I think there are some studies which shows that they have some beneficial effect, but these are all down the treatment chain. Because if we think of the treatment strategies for the dyspepsia, the first one foremost is the H. pylori and the PPI, which are the two important therapies. And if the person is not responding to the therapies, then we have important group of the drug, which is neuromodulating agents. The basic cause is because they say that it is the visceral hypersensitivity which is causing dyspepsia. So here comes the role of tricyclic antidepressants. The most commonly used is amitriptyline, and that has to be given in a proper doses, starting from like 10 milligram, building up to in every 1 to 2 weeks, and going up to maximum of 50 milligrams. So these are the important group of the drugs. And depending upon the symptomatology, if we're considering it's postprandial distress, then we can consider for the prokinetic agents and some kind of fundal relaxing therapy. The important fundal relaxing therapies are like we have this acosciamide, which is anti-acetylcholinesterase inhibitor, which improves the gastric accommodation. The other one is 5-HT1A agonist, that is buspirone and the sumatriptan, which are the fundal relaxing agents. And then comes the neuro cognitive therapy also, because a lot of things, the dyspeptic symptoms, they are coming from the disorders of the brain gut axis. But yes, definitely these adjuvant therapies, mostly herbal medicines, which is basically STTW, which you mentioned is a combination of 9 ingredients like licorice and some other things which has been given, and it has been tried that they enhances the effect of all these therapies. So if the person is not improving with all the traditional therapies, then these therapies can be considered. But I again, these therapies are not easily available anywhere.
Yes. There is, of course, you told like neuromodulator and prokinetic and the fundus relaxing therapy. How commonly are you using it? Because our daily, doctors want to ask when he has to start or when he can refer to the higher specialty to use this.
Okay. See, the neuromodulator therapy is basically if we are suspecting if the person is having some kind of visceral hypersensitivity, then these kind of the therapies can be beneficial. If the person is not responding to the standard doses of the PPI therapy, which you have given in the standard doses for a duration of like 4 to 8 weeks, and the person is not having any improvement in the symptoms, then neuromodulating therapy can be considered, because one of the pathophysiological mechanism of dyspepsia is the gastroduodenal neuromuscular dysfunction. So by improving that hypersensitivity part, and the other thing is the person having post distress syndrome, post prandial distress syndrome, in that fundal relaxing therapies can be given, can be tried before labeling that the person is resistant to the therapies. So I think prokinetic is in, especially the cosiamide and some kind of antidepressants we are using in our practice, and they are beneficial for the persons who are not responding to the standard PPIs and H. pylori therapy also.
Yes, yes. Thank you, ma'am. But coming to this PPI, because a lot of doctors are using the PPI for the dyspepsia, there's a like what is long-term use, and because their patient is coming up with a other kind of a problem because of the long-term PPI. So what they are saying that what is the effect of long-term, and what you mean by long-term use of PPI?
Okay, once if we are giving PPI, the clear indication is that once a day dosage of the standard moderate doses of the PPI is recommended. We don't recommend the twice a day doses for the dyspepsia. And apart from the PPI, we have H2 receptor antagonist also. There are specific guidelines which is given by American College of Gastroenterologists Association and Canadian Association also, which says that if the person is having uninvestigated dyspepsia, then we can give trial of PPIs. But if the person is having functional dyspepsia, then we can give a trial of H2 receptor antagonist also. And this, it's very controversial with the PPI more efficacious as compared to the H2 receptor antagonist. But yes, PPI is in the standard doses, and the duration is up to 8 weeks or maximum of like 3 months, but not beyond that. So after that, if the person's symptoms have improved, they can stop the therapy and can be used as an add-on therapy when and as and when required. There is no need to continue the therapy for a longer duration.
Ma'am, one thing is PPI is most abused drug by the
Yes.
patients, and what is and they are sometimes they take it as 6 months, and there is one of the data which say that when patient come to the doctor, they will see the prescription, they don't see the PPI because
Hmm.
the patient automatically say that okay, it is a lifelong therapy and he is taking it. So what is the harm or effect after patient is taking 6 months or 1 year of PPI continuously? Because there's definitely maybe some symptoms.
Yeah, I think you're right. PPI is one of the drugs which is easily available, and people not only 6 months, they people use it for years together. We have seen patients the OSIP की tablet है वो रोजाना खा रहे हैं, irrespective of the fact that they are not aware of the adverse effects which the PPIs can have. Some, because there is now some warning issues against the PPIs also, and it has been given on their strips also. There is a chances of nephropathy with this PPIs, which is a very important adverse effect, and that should be told to every patient also. In my clinical practices, I always prefer to give for some duration and then stop it. Thus, so this is our responsibility to uh, to aware the patients of the side effects of the PPI, especially in the form of nephrotoxicity, which these patients will not be aware that these PPIs on a long term can cause these kind of symptoms. And some kind of platelet disorders can be has been mentioned with the long term PPI use also.
Yes. In the similar kind of a journal, they say that PPI will reduce the gastric secretion, and on the longer term, it will increase the bad bacteria. That the good and
Yeah,
bacteria, there is an increase in bad bacteria, and that leads to a lot of complication. What is your
complex.
intake and how it is?
Okay. See, we have a lot of beneficial microorganism in our gut, which we called as it's our gut microbiota. And any kind of the antibiotics or what you say now is the PPIs, they can have some effect on the quality and quantity of these gut microbiota. And these gut microbiota are important not only for the gut mucosal system, but they are important for a variety of other mechanisms also, because they are important part. They play a very important part role in epithelial cell proliferation. They are important in mucosal cell defense mechanism. They are a part of vitamin synthesis, and they are a part of other types of the defensive mechanisms which is there in our body. So if we are giving for a long term, so somewhere they can affect the our microbiota which is present in our human intestines, and so can have a long term health consequences, maybe in the form of cardiovascular health, maybe in the form of increased atherosclerosis, some cancer risk also, and some kind of irritable bowel syndrome, IBD symptoms. Matlab, there means there can be onset of the few adverse effects if this gut microbiota they are disturbed.
Yes, it is a suggestion that you have to always discuss with a physician. We are not supposed to take more than whatever is prescribed. So one of the article they discuss about the intestinal dysbiosis. That's what you are discussing about it. You come across any intestinal dysbiosis complaint from the patient in your practice or anywhere?
Okay, intestinal dysbiosis. I don't think personally feel that person will complain himself or herself that the person is having intestinal dysbiosis. That possibility of intestinal dysbiosis has to be kept in mind from a clinician point of view. Like if the person is on multiple recurrent use of the antibiotics, if the person's symptoms are not improving with the traditional therapies, then we can consider that this person can be considered for giving some probiotics to restore the intestinal microbiota. But
Yeah.
as a person coming that they are having a intestinal dysbiosis, I am not aware of any particular symptoms that they can complain of apart from this routine belching and some kind of diarrhea, constipation, and other kind of complaints.
Yes, yes. It is clearly mentioned in your discussion that there is a change in bad or good bacteria that is called dysbiosis. So now I feel that there is a prominent role of probiotics to manage intentional dysbiosis.
Yeah, probiotics are now in 21st century. They are upcoming therapies, or what we call is the biotherapy, to restore the microbiota of the normal intestine. Basically, probiotics, by definition, which has been given by World Gastroenterology Organization 2017, which says that these are the living microorganisms which, when given in sufficient amount, can confer health benefits to the person. So, this means that these are the only microorganisms which we are giving in externally in some kind of tablet or capsule form, just to restore the good bacteria which is present in our intestine. The most common microorganisms which are used in probiotics are the lactobacillus, saccharomyces, clostridium, and then is bacillus bacteria and lactococcus. So these have been used for various therapeutic purposes. Regarding the clinical implications, in which kind of diseases they have been tried in like IBS, IBD patients, some kind of autoimmune problems, some kind of cancers, persons having resistant vaginitis, and they have been tried in patients of allergic disorders like atopic dermatitis. Apart from this, and tried in hepatic encephalopathy, H. pylori treatment also as an adjuvant therapy. So there has been number of practical application. Now we have upcoming role of probiotics in the diabetic patients also, in hypertensive patient also, in the role of in the management of obesity also. So it's very important. These probiotics are just can be as used as an add-on therapy just to enhance the digestion and not routine in medicines.
Yes, it is clearly say that your gut health leads to the lot of reduction in a chronic diseases in the future. So healthy gut is a healthy life. That's what we thought about from this. If that is the case, can we include PPI along with the probiotics in whenever the patient comes with a gastritis or the dyspepsia? Is it recommended? What is?
The role of probiotics in dyspepsia is ongoing studies are there. Not much data is available right now. We need more large quality RCTs to clarify whether dyspepsia and probiotics is really beneficial in dyspepsia or not. But whatever studies have been done, the meta-analysis of all these studies, they show that yes, probiotics they can be used in dyspepsia. They have very important beneficial role in decreasing the dyspeptic symptoms in the person who is taking routine PPIs and not responding to the therapies also. One of the studies that has mentioned that not only probiotics alone, but probiotics if given in combination with the prebiotics or what we call as the symbiotics, they have a better beneficial effect as compared to the probiotic alone. So some of the studies are there. These are the upcoming studies which show that yes, probiotics it can have a very beneficial role in dyspepsia in the persons, that it improves the quality of life, improves their dyspeptic symptoms.
Yes, you are absolutely right. That is because there's a lot of study on role of probiotics in diabetes, hypertension, in some
Yeah.
in diabetic foot ulcer also. So there is a upcoming, and along with this antibiotic resistance, especially in the COVID situation where the patient is abusing lot of antibiotics, even the doctors are saying, especially in this situation, same thing happens. So it
Mm.
is better to use probiotics when the patient is taking any medication, especially for the COVID situation right now.
Okay, not exactly. Actually, generally we have this antibiotic awareness in our communities also, and I think in the upcoming times, if the clinicians take the responsibility, the population can be made aware that not to use antibiotics. The only thing that is the antibiotics are available over the counter. So the pharmaceuticals, this pharmacists, they have a full right to give whatever antibiotics they want to give. But now we have a rising concept of probiotics among the general population also. They are now much aware about what are the probiotics, and they themselves they ask whether we need a probiotic or not. And it has been seen that if we give probiotics in the general prescription along with some other, there is some improvement, some kind of psychology, maybe some kind of psychological or some kind of objective sense of well-being to this patient. But until and unless we have clear-cut guidelines where to use probiotics, I am not using it right and left in the routine prescriptions. Until unless if the person is having some infectious.
Yes, there is say that role of probiotics in pediatric diarrhea. There's any role in this?
uh, First episode of diarrhea, no rule. But if the person is having recurrent infectious diarrhea, for the prevention part, we can give, and especially the person who's having where we suspecting Clostridium difficile, then we have definitely for the prevention and the treatment for the recurrent diarrheas or what we call as a Clostridium associated diarrhea.
Yes, we have got many comments here. I will take a specific, which is already you mentioned many of these comments. for that, but I will take some of these, which is very helpful. They are saying that recurrent blisters in mouth and burning in stomach or heartburn, of course. But regarding the blister in mouth, is it probiotics will helpful for this kind of a patient?
Yeah, we generally give in a routine prescription the probiotics for the oral ulceration or recurrent oral ulceration may be helpful in restoring the normal flora which is there, and yes, that it has a role.
Some of the doctors is asking here that role of probiotics in the liver cirrhosis. There is any role or the reduce the inflammation of the liver like the hepatitis and all. Is it any role in this benefit of probiotics?
Some role of probiotics in hepatic encephalopathy has been mentioned, but as such in liver cirrhosis to decrease the degree of liver injury, to decrease the inflammatory process, there is no such data available. I am not aware of any such data, and I am not using in my practice.
Right, yes. Here there is a lot of they say that because of the now because of the COVID or any other maybe family pressure, there's so much of anxiety nowadays. There is a very difficult sometimes go out. There is a COVID inside also the COVID another pressure. So this kind of anxiety since 2 years, it will cause dyspepsia in a longer term, and how to prevent it if that is true.
Okay. See, dyspepsia definitely has some relation with the anxiety and depression both. The more relation is with the anxiety, and it can cause dyspeptic symptoms. But since the last 2 years, we have seen first wave, second wave, and the third wave, and in my clinical practice, I have not encountered the person who are coming with more of dyspeptic symptoms primarily because of COVID or because of post-COVID sequelae. The more is the person is having anxiety, that is okay. But anxiety leading to tachycardia and palpitation, that is more common rather than the dyspeptic symptoms.
One of the question which always comes: can I use curd instead of probiotics?
Yeah, curd is a very good source of probiotics, which is basically a fermented thing and having the lactobacillus. But if we talk about the probiotics, we generally refer to not only curd, because curd is having a specific strains of the probiotics for for different kind of the diseases or for different kind of health conditions where we want to give particular kind of the probiotics. It actually depends upon the strain of the probiotics. Probiotics is not just lactobacillus. Probiotics means there are so many other organisms also. So depending in what condition we really want to give probiotic, whether curd alone will be sufficient enough to replace in that particular need, and also the probiotic, because for a probiotic to be effective it should be minimum 10 raised per 7 to 10 raised per the 8 colony forming units. So depending, so curd I am not sure what strains it is actually having and what amount it is actually having. So probiotics in particular strain form and particular quantity form will be effective only, and that's why we have different generation of the probiotics. We have first generation of was there, which was just a lyophilized form, not covered in any capsule form, used to get destroyed by the acidic environment, pH of the stomach, and have a very short shelf life. Then came the second generation, which were encapsulated form, better survival, so that the sufficient amount of microorganism can reach the colon where their desired effect is required. Then we can have the third generation, which are released in microcapsule forms. There is a slow release of the probiotics in that, and leading to more beneficial and long term effects. Then we have third form of fourth generation of probiotics, which is actually in a biofilm. Biofilm is this microorganisms, they are adherent to each other and they are adherent to the surface of the host also. So in this way we have different generations of the probiotics in the development phase. Not the main limiting factor for the probiotics is the delivery system, how they are delivered to the colon where they are actually required. So curd alone, whether will be able to fulfill all the needs of the probiotics in particular amount, that will differ.
Yes, yeah, that is the nice suggestion because instead of wherever possible, go for a probiotics as suggested by their physician and the doctor. Yes. One question they say that can I increase the dose of probiotics depending on the age of the patient, or can I go for all like
Okay, again, the my answers will be the same. Depends on what condition the person is trying to take the probiotics. It for general health, I don't think we are giving probiotics for overall general well-being of the person. In particular disease conditions, we are giving probiotics. Like if there is some diarrhea, some kind of clostridium infection, some kind of allergic reaction. So different studies are showing different strains of the microorganism which are effective in a particular condition and particular amount. So we can't go unevidence, or like we have to go according to the scientific evidence what the trials are saying. So these, that's why we have different probiotic combination which are available. Some are single strains, some are multi strains also. And still we are not very sure whether multi strains are more beneficial than a single strain. Multi strain can have a more synergistic effect, they can have a mutual tolerance and mutual inhibition factor, but whether they are really effective in all kind of pathologies where we are giving, that is just still controversial. So until unless we have a definite scientific evidence available, we can't think that we can increase the dose of probiotics at our own choice. We have to go as per the evidence available.
there is one question they are asking like whether there is any role of probiotics in bacterial vaginosis.
Yeah, in bacterial vaginosis or vaginitis, there is some role of there is a role of probiotic that has been mentioned.
Yes, there is a many questions, but because of the time schedule, so I will take the last question. If you are, yes,
Yeah, yeah,
one
go
of
ahead.
yes, one thing is about the counter, over the counter. So, as a patient can go and take the probiotics over the counter, and is it suggested, or what you suggest for this patient?
See, probiotics, when we think that probiotics have all beneficial effects, but do they have adverse effects also? Nobody knows. Actually, adverse effects, most of the trials are not showing any particular kind of adverse effects if someone is consuming it over the counter. But if someone is want to consume it from the over the counter without any medical prescription, then my suggestion, my advice will be just to be aware of the adverse effects of the probiotics, because somewhere these probiotics can have little bit of adverse effect, and these adverse effects have been seen most commonly in neonates or premature infants in some kind of immunosuppressed states. In critically ill patients, they can have some adverse effects of the probiotics, so especially the persons who are in central venous catheter sector. It has been mentioned in the literature. So not every drug which is available over the counter we can't take of just it's just like an antibiotic, or just kind of any kind of analgesics or NSAIDs or whichever is available. So my personal opinion is not to go for over the counter without any medical prescription. Because ultimately they are the drugs, and if you want to use it as in a food additives, yes, probiotics, they are now provided in some food additives also, where it is relatively safer to use.
Yes, there was a very nice discussion, and we got a maximum answers. And during this chat show, before ending to this session, what is the few pointer which you want to give to our delegates, the audience today?
Okay. I'm a physician, and dyspepsia, when I was given this topic, this is purely gastroenterology topic. And we take dyspepsia as just as a um, routine complaint which a person which we see in our OPD setup. But once we are seeing a dyspepsia person, we never see what kind of dyspepsia, like what subgroup of dyspepsia, and where to target these patients. We general tendency is to start all with the PPI therapy. And H. pylori testing, we don't go for the H. pylori testing because in India we say that H. pylori is very endemic, and even if we treat the H. pylori, the chances of reinfections is very high. But still, this is one of the thing that we as a clinicians, they don't go for H. pylori testing and like urea breath test or stool antigen test. Seroprevalence we can't rely because 80% they are seropositive, but definitely H. pylori testing and should be tested maybe from the biopsies if available, and always look for the alarm features, and depending upon whether it's postprandial distress, whether it's epigastric pain syndrome, and always use the neuromodulating and the other kind of the drug therapies in every dyspeptic patient if they are not improving with the PPIs therapy, and always to make aware them about the side effects of the PPI, because PPI is one of the drug which I have seen in every prescription. Whenever a person comes from any hospital or from any other medical practitioner, the every prescription is having this PPI. Whether we really need to give PPI in a person who is not having dyspeptic symptoms is really we have to think, because if we put treating for some infection, why to give PPIs to these therapies along with these therapies? So these are the important point. A lot of medicines we are overusing from our end, so that can be just we give a point to think about whether we really need to give it or not.
Yes. Thank you. This was the very concise and brief and very informative session. But this is the topic where you can discuss for a day together. There is no
Yeah,
limit of this. So, but there is a time limit. Of course, with the so, with the approval from you, we can conclude the session. Is it?
yeah, and
Yes.
thank
Yes.
you,
Thank
Dr. Santosh. It was very nice interacting with you also. The way you moderated the session is really commendable, and thank you all.
thank you, ma'am, and thank you for wonderful session and for the organizer. Thank you for the opportunity. Thank you.
Okay, good night.
Thank you, sir.